So to kick us off, I just want to announce you might be seeing some notice in front of your device, your mobile phone or your laptop, letting you know that this event is being simultaneously broadcast to the global community on YouTube as well as on Facebook. So we are really excited that you are here with us. All right, so without much ado about nothing, we are going to kick off with Brown. Do we have the agenda? Or do we go straight to the presentations? All right, so this is a run of the meal. Romy Azuing again, I am introducing, and then we're gonna have introduction by faculty and staff. And then after that, we are going to go directly to the presentations. During the presentations, each of the Public Health 360 fellows will introduce themselves. They will tell us where they are calling from, where they're joining from. They have been with us in the last 3 months. They will tell us a little bit about their passion, what brought them to public health, and hopefully they can also let us know where they hope that the journey in public health is going to be joining them. So, Moses Avasong, thank you so much for joining us from the beautiful country of Ghana. Ghana is an incredible country. Thank you so much for joining us all the way from Ghana. All right, so the next one, let us see which faculty do we have to introduce themselves. I am the lead faculty here. I am so fortunate that I'm working with a group of staff and faculty who are really helping me to lead this program, to develop, to identify, to develop, and to mold the next generation of public health professionals from all over the world, incredibly from all over the world. So my background is in public health. I have both my master's and doctoral degree in public health, and I live in Maryland with my 2 beautiful children and my wife. All right, who is next, Brown? All right, so here are the faculty that are working with me. I'm gonna let them introduce themselves, beginning with Dr. Susan Ekejuba. Susan?
Hi, everyone. Thank you, Dr. Rami. My name is Dr. Suzanne Ekejuba. I am one of the faculty at Global Health and Education 360. So specifically, the program manager here at GHEP and one of the faculty for PA 360. My backgrounds are in veterinary medicine, pharmacology, and data analytics. So welcome everyone. We are happy we have come to the end of the program for this cohort, and thank you. And that's it from me.
Thank you so much, Dr. Susan, for the incredible support you've been providing to our fellows all these 3 months. Next, I have Dr. Chidubem Eboluche. CJ.
Hi, good morning, everyone. I'm sorry I can't come on camera actually somewhere. My name is Chidubem Eboluche, and I have a veterinary medicine degree from the University of Nigeria, Nsukka. I have a master's in public health degree from Howard University, currently a doctoral student of Morgan State University in public health. And currently work as a health service advocate with a non-governmental organization in the United States, and working with GHEP as an administrative assistant. Nice to meet you all, and I'm very happy and excited with the knowledge you guys have gotten so far in the program. Happy to see what you would achieve in the field moving forward. Thank you.
Thank you so much, Dr. CJ. And I have Brown Magnus Olivers. Brown?
Oh, thank you, Dr. Remy. So my name is Brown Magnus Olivers. I have a degree in computer science from Abia State Polytechnic, and I've been working with GHEP for a little bit of 5 years now. And I work as the IT and outreach coordinator, and Looking forward to this wonderful presentation. Glad that we've come to the end of the summer cohort, and I'm looking forward to the presentation. Thank you so much.
And the last but not the least, Dr. Nzube Eboluche. Zubi.
Oh, sorry about that. Good morning, everyone. My name is Dr. Nzube Eboluche. I'm the program navigator with the Global Health and Education Project's Public Health 360 Fellowship Program. And I work with the Maryland Department of Health as a research data analyst. And my first exposure to public health is actually working with Global Health and Education Project. So I will tell you, you guys have really come a long way, and this will be a life-changing, career profession for you, because all the things you've learned here, you will definitely use it in one way or the other. Because my training wasn't in public health, but going through Public Health 360 Fellowship Program really gave me that background and all that I need to venture into public health field. And currently I work with the Maryland Department of Health as a data analyst. So I'm really looking forward to seeing what you all have. And I'm, so keen to learn as much as possible from everyone. Great to see everyone today. Thank you.
Thank you so much, Dr. Zubi. And welcome to Eugenia, who has joined us from New Jersey in the United States. Thank you so much, Eugenia, for joining. All right, so we have come to the time that we have all been expecting. These fellows have, in the last 3 months, passed through what I consider one of the most gruesome semesters in US education. For the first time, I think a number of them are working with individuals that come from different parts of the world, which is really, really an incredible opportunity, having individuals that come from different parts of the world who you share with. So today, we are going to be hearing 2 incredible programs that they created. So the Public Health 360 Fellowship's goal is actually to get public health professionals ready for public health on day 1. So we take individuals with different backgrounds from different areas, from different parts of the world. We put them through our 3 months training. And those training include competency-based training, hands-on work, program development, and insider information, and then also pitch sessions. We believe that at the end of this program, they get better in what they are doing. If they are looking for entry-level positions, they have more confidence to ace those interviews. And if they are looking to open public health NGOs or entrepreneurship, they have received the founding and the foundational skills that they need to run those programs. So we are so proud of them. I know that in the next few months, we will begin hearing good news of where they are and how they are transforming the society and the community where they all live. So please join me and let us give all of our graduating fellows a resounding round of applause and everything you can use in Zoom to show your excitement. I have bouquet, we have love, just show them some love, right? I have many things that I have thumbs up, I have everything. They deserve everything. And if you're a family member joining us today, I want to thank you. I want to thank you for the support you have given them, hours and hours of work, hours and hours of waking up in the night to work with colleagues who are based in different parts of the world. I want to thank you for offering them the support on this journey. Without your incredible support, we would not have 6 graduating fellows. I want to give you an idea of how tough this program is. They started obviously with more than 6 people, and they are graduating only 6 people. So that gives you an idea incredible people that are qualified, really who have accomplished a lot, but the demands of this program gets sometimes very, very rigorous that unfortunately many people fall through the way. So having 6 out of the many people we admitted for this cohort is really incredible. All right, so without much ado about that, we're gonna hand over. Here is who we are. You have met all of us. Myself here, this is my information, and then Dr. Susan and all our faculty. Please, if you are considering, learning more about public health, we ask you to reach out. If you are considering, or you have a friend who is doing public health and you want them to get better at what they're doing, reach out to us. If you are not even sure whether public health is for you or not, you may have studied other courses, other professions. This is an incredible time to be in public health. So please reach out to any of us here, and we'll be ready and willing to talk you through, to give you some mentorship, and to see whether the PA 360 program might be the pathway that you've been looking for in order to enter the field of public health. I don't usually disclose this, but I want to let you know that there is no better time to be in the profession of public health than now. The jobs are booming. I know that where I work, I see many people looking for public health professionals. They can't find anybody. They are looking for people that have skills. They're looking for people who can come in and do the work, and they can't find anybody. They advertise positions. Before they identify individuals, those people are already hired out. So if there is a time to think, even as a side hustle, this is the time. If you've ever been thinking about creating an NGO or a nonprofit organization in public health, this is really, really the time for you. And that is what this program does. Geography is no longer a barrier. We have a number of candidates here who are joining us from Lebanon. We have a lot from Nigeria. We have had students from India. We have had students from Myanmar. We have had students, of course, from our neighbors here in Canada, as well as our students who are in the United States. But geography is no longer a barrier. You can join the program from anywhere you are. The key is that you will leave a totally different person, and having some clarity as to where you want to go. I am in public health. I can tell you this field is booming. This field is paying. This field is really more and more being appreciated. And one thing I love about public health is that you can combine it with anything. You studied computer science, you can combine public health with computer science. You studied chemistry, you can combine public health with chemistry. If you studied physics, you can combine public health with physics, which is why the interdisciplinary nature of public health is really amazing to me. If you're a clinician, or a clinician, you're a nurse, physical therapist, occupational therapist, a physician, a medical doctor, a pharmacist, and you've always been looking to get into public health, this course is for you. 3 months from the comfort of your home, but willingness and readiness to really challenge yourself to the next level and opening up opportunity for a career of a lifetime. Thank you so much, Brown. Now let's go to the first group, and I am going to sit back and enjoy today's program. Just remember, we don't know about these programs. This is a classic problem that was presented to all of these fellows, and we asked them to create a solution. So you are hearing the solutions just as all of us are hearing the solutions today. Write down your questions. Write down anything you want to ask them. I have a long list of questions ready as I'm hearing them, and I know they're going to do us proud. So Brown, let us give it to group number 1. Who am I handing over to?
So that would be us. Hello, everyone. Just give me a moment to share my screen. Okay, and I just want to confirm, can you see the slides? Or one slide at least. Okay, thank you. All right, So yes, hello everyone. Thank you for being here today. We are very pleased to present to you our capstone project. We are group number 1, which consists of myself, Queen Jacques, Yasmin Jafar, and Mira Ikram. And the title of our project is Maternal Net, or MatNet for short. And the net in this title represents network, just for clarity. So let's dive into the program. So actually, before we dive into the program, we'll introduce ourselves. So I will start off. Like I mentioned, my name is Queen Jacques. I am a doctoral candidate, so Doctor of Philosophy candidate in medicine. And I have an undergraduate degree in neuroscience and mental health. I am currently located in Newfoundland and Labrador in Canada. So I'd just like to take a moment quickly to just acknowledge the land on which I'm residing on and presenting to you from as the unceded traditional territory of the Beothuk and Mi'kmaq people, whose culture has now been erased forever and cannot be recovered. So I'm privileged to reside here and to present to you from this beautiful land of Newfoundland and Labrador. My passion for public health stems from, or my reason for being in public health stems from my passion of wanting to increase the quality of healthcare for marginalized communities and also bring forth more health promotion, health education, and prevention strategies in healthcare. So that's a little bit about me, and I look forward to presenting for you guys today. So I will now pass over the virtual microphone to Yasmin to introduce herself.
Thank you, Queen. Hello, everybody. Good morning, good afternoon, in all parts of the world. My name is Yasmin Jafar. I am talking to you guys today, presenting to you from Treaty 6 territory, Edmonton, Alberta, Canada. I am a PH 360 fellow with JHEP and also an MPH candidate at the same time with a strong interest in epidemiology. Particularly the thing that I would say drew me to public health was the issue of non-communicable diseases, particularly in low and middle income countries. So with my public health education, I hope to contribute to alleviating the burden of non-communicable diseases in countries around the world. I'll pass it on to Mira to introduce herself.
Hello, everyone. I'm Mira Krayem. I'm a Palestinian refugee based in Lebanon, Beirut. I graduated from the Lebanese New University with Bachelor of Speech Therapy, and then I was engaged in public health projects in the Palestinian camps, which have miserable circumstances of health institutions and hospitals. So I've dedicated my studies and work to know more, to raise my knowledge until I can help my community better. And I will go back to Queen and for her to start with our project.
Thank you. So thank you both to Yasmin and Mira for their introductions. So moving forward, again, just a little bit before we get into the excitement, I just want to orient our audience members today about our agenda for our presentation. So we will first begin with our mission statement for our program, then go into some background information and the problem statement that inspired the program, and then dig deeper into what the program is, along with its goals and objectives, the methods and program activities, and the timeline of the program. And then we will also highlight some barriers and some of the expected outcomes for the program. And then wrap it up with acknowledging our partnerships, the evaluation and dissemination of our program, our proposed or requested budget, and just a final summary of everything. So to get into it, the mission for our Maternal Net program is what guides our every move and decision. And it articulates our purpose, our commitment, and the change we aspire to bring about. So our mission is very simple. It is to help moms and babies thrive. We're here to provide information, support healthy choices, and make sure every mom gets the care that they So in a world where maternal challenges keep persisting, not just in the US, but globally as well, this is the mission for our Maternal Net program, and what drove our objectives all the way to our strategies and expected outcomes. So our program is rooted in this mission of helping moms and babies thrive. So just to ensure a bit of clarity and shared understanding, we will be talking about some of the contextual background. So there are some words that that some people might not be familiar with. So we just want to provide clarity as to what some of the words mean when you hear us say it. And don't worry, there is no quiz or test after this, so don't feel pressured to memorize this. It's just for familiarity. So to begin, one of the words that we'll talk about a lot, and which I've already said, is maternal. And this just means anything relating to mothers or pregnancy. The next is mortality. So this is simply but tragically just means death. Morbidity is referring to any illness or health problems. And then when you put maternal and mortality together, it is the death of mothers during pregnancy, childbirth, or shortly after. As well as live births. When we speak about live births, it means that babies who are born alive. And the opposite of that is the stillbirth, which is babies who are born not alive. And then lastly, health outcomes. So this just refers to the results of a health condition or the results of a treatment. So what were the actual results? So like the overall well-being and recovery. So those are just a few of the keywords and that we'll be throwing around throughout our presentation. Okay, so to get started, I think I've teased you enough. So to get started, in order to appreciate where our program comes from, we have to fully talk about the significance of what is happening in the US right now with maternal mortality. So with maternal mortality, there has been an increase in the maternal mortality rates. So depicted in this graph here, let me just see if I can change my pointer here so you guys can see it. Okay. So within this graph, it shows the rate of maternal mortality over the last, or over 4 years. So 2018, 2019, 2020, and 2021. And then on the x-axis here, you see there's different age groups. So under 25, 25 to 39, and 40 and over. And then on the y-axis, we have the number of deaths per 100 live births. So the number of deaths per 100 babies born, the number of deaths of the mothers. So what you can see in this graph is that in each age group and every single year between 2018 to 2021, the maternal mortality rate has increased. So for example, in the 25 to 39 age group, you can see in 2021, there was 31.3. The maternal mortality was 31.3 per 100 live births. So meaning that 31 mothers died for every 100 babies born alive. And so obviously this is quite troubling. So that is the landscape. So this graph only goes up to 2021. The 2022 results have not been released yet. So, but we can see that regardless, within these 4 years, it keeps escalating. So to go even further into the statistics and the data, we can look at and see, we can stratify or like divide the data by race and ethnicity. So actually, before I go into that, I just want to bring your attention to this first part of the graph, which is just the total maternal mortality rate, regardless of age, race, or ethnicity. So it's just the total maternal mortality rate in the United States. And as of 2021, it was 32.9. So again, 32.9, or we can roughly say 33 mothers died for every 100,000 babies born alive. So it is still increasing as shown like within the age as well. So when we divide it by race and ethnicity, the three major races or ethnicities that we have are non-Hispanic white, non-Hispanic Black, and Hispanic. And you can see, similar to the age groups, in every single group, the maternal mortality rate is increasing. Now, what is of particularly concerning is the Black race and ethnicity. It is in 2021, the maternal mortality rate was about 70 deaths per 100,000 live births in just the Black women population. So that is definitely concerning. And these alarming disparities kind of are like the impetus for like the urgent demand of public health addressing maternal mortality as well. So just to further reiterate that point, so maternal mortality is 2 to 3 times greater for Black women in the United States. And so it is very troubling to see. And we do need to put forward some action and interventions to help reduce maternal mortality for everyone, but especially those in marginalized communities. So within the data as well that is released by the Centers for Disease Control and Prevention, they also mentioned that of these deaths, there's 4 out of 5 pregnancy-related deaths that were preventable, which is pretty high. So that's about 80% of the deaths that happened, they were preventable had they been screened or had there been a better quality of care. And so within that as well, so more than half of the deaths that occurred were actually within a week to 1 year after birth. Contrary to some misconceptions, people think that it's mostly during pregnancy, but only 22% of women actually died during pregnancy. And then 25 women died like the day of delivery. But knowing that like 80% of those could have been prevented is a very big number. And it does give us like a beacon of hope that we can do something now to kind of intervene and hopefully reduce maternal mortality. So to go into, well, now that I've showed you some of the statistics and the scales, it's also important for me to also show you what are the causes of some of these deaths. So mental health conditions is one of the causes. So deaths by suicide and overdose poisoning related to any substance use disorder. So 23% were mental health conditions related deaths. 14% were excessive bleeding, so that's also known as hemorrhage. 13% were cardiac and coronary conditions, so anything relating to the heart. 9% were infection related. Another 9% was thrombotic embolism, so that's a type of blood clot, and blood clot is when your blood essentially like clumps up together and blocks veins or arteries. So that's 9% was due to that. And then another 9% was cardiomyopathy. So that's the disease of the heart. So you can see here that there's at least 2 or 3 that are relating to the heart. And these are all things that we do know a lot about and can prevent. And then lastly, hypertensive disorders of pregnancy. So this relates to high blood pressure, or formerly known as preeclampsia, and that was about accounted for 7% of the deaths in maternal mortality. As well, just like I showed before with the mortality rates, you can also see that there are some differences within race and ethnicity for the causes of maternal mortality. So for white and Hispanic women, for the primary cause of death was fatal outcomes by suicide or drug overdose. So that's that 23%. And then for Black women, about 16% was due to cardiovascular issues. So anything relating to the heart. And then for non-Hispanic Asian people, hemorrhage, also known as blood loss, was the leading underlying cause for death. And there's no statistic for this one at the moment, just due to the source from the CDC. It wasn't able to give any statistic, but it's still something that we should acknowledge. And we do know that it does happen predominantly in the non-Hispanic Asian people population. So yeah, with these insights, the disparities within mental health are definitely a motivation or inspiration for the need to have like intervention programs that address the needs of each group, but also just as a whole for maternal mortality. So as well as just finding out what causes maternal mortality, it's also important to know like why this is happening. So these are some of the factors that may be able to explain why maternal mortality is high. So first, lack of access to healthcare. So some mothers are unable to get basic care that they need, or they're not able to access those health services available to them, as well as like lack of access to quality prenatal and postnatal care. So the quality of care may not be adequate, or they don't have enough services in the area that they are, or the hospital or clinic. Also, cleanliness of hospital and clinics is a factor in the quality of care. Third is the chronic health conditions. So some mothers may already have health conditions that they have been trying to treat and like throughout their life or at some point in their life. So these can complicate pregnancies as well. And then we have as well socioeconomic disparities. So things like low income, like being from a low income family, or being low income yourself, lack of education, and maybe differences in employment salaries or employment stability. This can lead to differences in the quality of care you get and the frequency of care you receive as well. And then we also have geographic disparities. So similar to socioeconomic disparities, where a mother lives, whether it's urban or rural, can also impact their access to quality healthcare. And then, of course, racial and ethnic disparities, which I've touched on a lot at the beginning, but there may be different health outcomes due to a wide range of systemic issues within the healthcare system towards different races and ethnicities. And then we also have maternal age, which I also showed earlier, that sometimes different age groups face different issues. But we do know that with both young and older mothers, they face challenges nonetheless. And then lastly, maternal mental health, so which is often overlooked, but I think is starting to get some light shed on it, is that after a mother's birth, a lot changes for them, especially in terms of mental health and also throughout their pregnancy. So a mother's maternal mental health is important because it impacts the well-being of themselves and of the child. So with all of these factors that contribute to maternal mortality, whether it's independently or in combination, they all play a role in maternal mortality rates. And the need to address them is very urgent. And any delays, as we've seen, can or could mean that more lives are at risk. And so addressing these disparities is not only a matter of health equity, but it's also a human right. So ensuring every mother has an equal chance at a safe pregnancy and childbirth is of utmost importance. So I just wanted to share this quote. So childbirth is one of the most profound experiences in human life. And with that sentiment in mind, Latham Thomas says that birth is meant to be a joyful and transcendent experience, and we have the opportunity to work together to restore safety and strive towards equity in birth. So this means that we all have a part to play, whether we are in public health or not, or just part of the general public. We can all advocate for this issue. And maternal mortality is definitely more about numbers and charts and graphs. Pregnancy is a real life moment, and the happiness that comes from it and should come from it is definitely important. So with everything that I've shown so far, it's definitely a call to action for us to make sure that every mom gets the best care that they need and that they're treated with love and safety. So having laid out all of this for you and the urgency of the issue, I will now step back and pass the mic to Yasmin, and she will introduce you to our maternal health program, which aims to address these very challenges I spoke of. So please welcome Yasmin.
Thank introduction. So speaking of the statistics and the risk factors that Queen just mentioned, we are presenting to you our problem statement for addressing this issue, summarized below. The United States faces a pressing and alarming challenge in maternal health outcomes, with maternal mortality rates rising disproportionately, particularly among marginalized communities. Racial disparities persist, exemplified by a maternal mortality rate 2.6 times higher for non-Hispanic Black women in the United States compared to non-Hispanic white women. Our proposed approach to tackling this problem is the Maternal Net program, which is shown in our app, which I'll talk about and define more in the next slide. So our program is driven by evidence and research, and it's a digitally enabled public health program that we aim to launch in a remote area of the United States in order to reduce rates of mortality through education and supports to pregnant women. Through funding from a previous grant, we've already established and developed the application that we will be talking about in the next couple slides. And we've developed it in a evidence-based way and made it user-friendly so that every woman who gets exposed or participates in the program is able to use it and to make better informed health decisions based on it. Through the application, we aim to support women who are pregnant through several engagement opportunities. One of them being the main one is giving them the opportunity to access holistic and easy access care, which has a comprehensive approach to maternal care. We take into consideration that we have a diverse background of participants, potential participants that can be enrolled in our program and have access to the app, especially in maternal care deserts around the United States. Through the app, we also provide them with real-time symptom tracking. And then with our partnerships, we're able to connect with local health departments, ensuring that the data that we track can be sent over to health departments, to healthcare professionals who can then be able to track, flag risky pregnancies, and intervene in timely manner. We also provide through the app educational resources that can support pregnant women, help them be exposed to the risks of hypertension, other cardiovascular diseases, and mental health issues. And through that, they can be better equipped and empowered to make health-informed decisions. We also give them access to healthcare professionals like medical personnel, which is especially timely in areas in the country where there's no access or there's no immediate access to healthcare centers or maternal care, which can then delay the incoming of care, which can be required at times. We also provide vital signs monitoring such that, as I mentioned before, risk factors can be identified by healthcare professionals and they can intervene in a timely manner. In the next slide, I'll go into more detail about the functionality of the app and the supports it can provide for pregnant mothers. So we break it down into 4 kind of umbrellas or branches. The first one speaks to tracking of health progress. So once a pregnant woman is introduced to our program and signs up to enroll, consents to be involved in our data tracking, we introduce the users to the welcome page through which they can input their demographic information, meaning that key health indicators such as blood pressure, mood, sleeping patterns, nausea, vision changes, and other health indicators will be tracked through the app. Through that monitoring, we are able to track the pregnancy journey and see if there's any complications that arise along the way. The data that we collect through the app will be followed and recorded and associated with the patient profile. In collaboration with our partners, like I said, we can then allow health practitioners to see the risk of complication and address it before it becomes fatal. The second one is equipping mothers with the knowledge and education on how to navigate the health issues associated with pregnancy, for example, hypertension and mental health as well. When we give mothers the access to these evidence-based knowledge education modules, they can become better aware of the health issues and maintain a steady understanding of them so that they can make better informed decisions to achieve healthier outcomes throughout their pregnancy. The third branch ties into the second branch, which just addresses the social dimension of health, which is equally as important and critical to maintaining a healthy pregnancy and postpartum period. In the app, we provide pregnant women to access mental health supports, being apps, being videos or other articles that they can read and learn about so that they can be better supported during that period. The last one I'll talk about is communication to telehealth consults with healthcare providers. So because we know that in some areas of the country, women don't feel empowered enough to go seek healthcare in centers because it's too far away or there's barriers to access, financial or social, we provide them the opportunity to connect directly through the app with healthcare professionals so that they can be supported at all times as needed. The next slide, I'll go through like a flow chart which mimics what we predict will be the user interface and how the different patients can go through the app to get the needs that they want. So this slide shows the flow chart, which is the overall user experience. When somebody signs up to enroll in our program, they start at the start point, which is in pink at the top. Then they go through the registration process. In the registration process, as I mentioned, we collect demographic information to create a user profile. We also get consent that they will be willing to commit to the program for the duration, so beginning from the pregnancy or if they're in their first trimester or second trimester, and up to a month or so after they give birth. Once we receive that consent and they're registered, they get introduced to the welcome page. And so the welcome page is basically like any app you would open that has a digital component of tracking timelines. They would be able to see what stage of pregnancy they're on, what the pregnancy week outcomes can look like. Then through that, we can also be tracking health indicators. Like I said previously, this doesn't have to be on a daily basis. Some prompts will be daily, some prompts will be weekly, and then monthly and so on. Once the daily check-in is complete, health metrics are tracking and we're doing the symptom tracking. The app stores that data, and then if there's any need for the data to be flagged for healthcare professionals, if there's a risk of hypertension, a risk of any other complications that can arise, the data will be flagged to the healthcare professionals so that they can intervene timely. Additionally, after the symptom tracking is done, they have access to the educational modules that I said before, so that can be videos, activities to reduce stress, and so on. They also have access to consult with healthcare professionals virtually and be able to be supported at all times. And there's also a feedback and reporting component to the app so that we can always be involved with the participants in engaging and bettering the app with them. In the next slide, we'll talk about the objectives of the program as a whole. Then we'll speak more about the methodology in the following ones. So our objectives are four. I'll go through them. The first one is to increase maternal health awareness and understanding critical maternal health challenges, including hypertensive disorders, blood clots, blood loss, and within underserved communities particularly. To enhance access to vital healthcare supports for pregnant mothers by providing telehealth consultations within the app so they can virtually meet with healthcare professionals. To predict and prevent potential health complications linked to maternal health through our data collection process and our partnerships with local health departments. And four, to foster health equity and community collaborations with healthcare providers, health organizations, local NGOs, public health leaders, and faith-based organizations to ensure that the whole community is coming together to address this really important public health challenge. In the next slide, I'll talk about the methodology that went into the design of this public health intervention. So first we start with our theoretical model. So the theoretical model or framework that this program follows is the health belief model, which essentially states that every individual's actions, behaviors, or actions towards health, their health and well-being, and how they take care of their well-being is ultimately decided by their beliefs. So we present this program with an approach towards health promotion. We want to reduce maternal mortality rates, and we're approaching it through health promoting and raising awareness about these issues. This follows the health belief model because we are introducing participants to the perceived susceptibility and severity of disease. So by introducing them to the risk factors, introducing them to knowledge-based modules about hypertension and other risk factors that can cause disease and fatality during the pregnancy period and after it, we are informing them about the decision, which then translates into perceived threat. They feel better they feel like they want to take action, and then that translates into ultimately decision-making for the better. The next slide shows another framework which is used for evidence-based public health programs, which is a PICO framework. So it just aims to specify our project scope and let the audience know what exactly is our target population, what the intervention are, what are we controlling the intervention to, and then the timeline and duration of our program. So the population we are targeting, the population of interest, is pregnant women in Phillips County, and I'll talk more about why that was our target population and the justification behind that in the next couple slides. Pregnant women in Phillips County at risk or diagnosed with hypertension. The intervention that we're proposing is a digital-enabled public health program that can equip them with the knowledge, awareness, and access to healthcare that can help reduce these negative health outcomes. The comparison is pregnant women in Arkansas or Phillips County that are not getting access to this application and instead are only within traditional maternal care means. The outcome that we are proposing or predicting is a reduction in the rate of maternal mortality in Arkansas, which has the highest rate in the entire country as per the data that was collected between 2018 and 2021. The time of the program or the duration is from the start of pregnancy up to 28 days postpartum. The next slide, we will talk about the justification for selecting the target population and the program implementation. We will plan to pilot the Maternal Net app in Phillips County of Arkansas, which is the state has the highest rate of maternal mortality. If you look at the map of the United States, which is shown to the right of the slide, the entire South region has higher rates than the average, which is 32.9, as was the range that was collected from the data between the 3 years that was mentioned earlier. But in the Southern region, it is significantly higher, and the highest state is Arkansas. Then within that state, we are selecting Phillips County. We aim to recruit 16 participants from that county. In the next slide, we will talk about the justification for selecting the population. So as I mentioned earlier, the geographic disparities are apparent. The southern region of the United States is suffering significantly more than the rest of the country from the maternal mortality public health challenge. Specifically within Phillips County, it was reported that in 2017, only 4 visits were made to seek maternal care in the health centers. So we clearly see there's a trend that's pointing towards a problem to access care, to get timely care, and that leads to, unfortunately, deaths due to complications during pregnancy. The other aspect that we're considering is racial disparities. Like Queen mentioned before, the rate of maternal mortality in non-Hispanic Black women is significantly higher, so we want to address that first. Phillips County is reported to have 63.9% of the residents be racialized residents. So we are targeting the population there because we know that this is a health problem, particularly in underserved communities. Moreover, we're only recruiting women who are in their first and second trimesters of pregnancy. In the next slide, we will talk about the recruitment strategies that we are approaching this problem with. So in order to recruit participants, we are organizing community outreach events in collaboration with our partners and involving the community in social and alternative media campaigns, remote workshops, and obviously our partnerships. So we are, as we'll talk about later, collaborating with local health departments, local NGOs who are really passionate about and committed to alleviating the problem of maternal mortality in the United States, and also faith-based organizations. So I'll go through a couple of our inclusion and exclusion criteria. Individuals that are residing in Phillips County are a priority. Like I said, that's our target population. The ages that we're recruiting from, we aim to get 2 individuals for each of the age groups. So, but the entire range is 14 to 35 plus, who are in their first or second trimester from underserved communities. Then individuals with the ability to use technology at a basic level. And then for the exclusion criteria, anybody who's not residing in Phillips County is not going to be included in our recruiting process. and in individuals below 15 who are not pregnant in their third trimester of the pregnancy, and anybody who is not able to use smartphones or electronic devices at a basic level. In my last slide, I'll talk about the methods and what exactly is the methods of engagement between the program and the participants involved in it. So what will the participants do? We kind of give a summary overview here. Like I said earlier, through the flow chart, we introduce every participant to the program and they complete a consent form, which says that they are committed to be in the program for 10 to 11 months, and they are willing to exchange data and track their health outcomes through the app. They will also be able to attend a MatNet app training session in person or virtually, just introducing them to the app, getting to know how they can use the different features to their benefit. They fill out a pre-programmed survey through the app and also log in to track health status. So I said the key health indicators, symptoms, relevant data on a weekly basis using the app interface. They also explore evidence-based educational resources provided in the app at their convenience when they feel like they need to address any challenges that may pop up. And also attend an end of program workshop in person or virtually. That gives us the space to reflect on how they felt about the app, what needs to be done, and what can be improved. So that ends my section. I will pass it on to Mira to talk to you guys about the next couple slides.
Thank you, Yasmin and Queen. Adding on what my colleagues mentioned, this project will be divided into 3 phases. Phase 1, the app development, which is already completed. It took 2 years. It was all about designing and developing the app, assembling a language model, which is AI, into the app, and testing the quality of the app features and assuring the measures, plus establishing the security and privacy app. It also included the recruiting process and the training of the healthcare provided who participated within the app. Now we move to phase 2, which the duration is 1 year. The first 2 months will be the implementation phase. In this phase, we will obtain the ethics approvals. We will have the workshops with stockholders. We will have the recruiting phase of participants, and all the purchase of the needed material will happen in this phase, plus the training and the completion of the surveys of the surveys and the surveys of stakeholders and partners that we will be mentioning in the coming slides. Then, in the 10 months after the implementation, we will be having the data collection. In this phase, where the work will happen, where the users will be adding their data into the app. They will be following the calendars of their pregnancy. They will be calling the health professionals within the app. And we will be having those data, the symptoms they're adding, the telehealth consultations, if they're happening, what are happening, and all the users will have access to education models like videos and articles about the maternal mortality, about the symptoms, and articles of mental health, which will support them. The last part of this phase, which will be up to 12 months, it's the progress. How we will check what's happening within the app. We will have monthly progress reports sent to the participants and the cooperative, which are the partners. We will have program evaluations, which will be conducted every 3 months in order to see if everything is going well within the app and to check the satisfactions of the users. And we will continue monitoring the app in a technical way, on a technical level. Now, for the last phase, which is phase 3, it will happen in the 2nd year. It is the dissemination phase. It's where we are gonna connect with people and outreach more people. Here's where the post-program survey will happen. Here's where we will analyze the data that we have from the app, from the stockholders, and then we will have an outcome assessment to check if we have reached our outcomes that we will discuss in the slides after this. And we will have the program report and the dissemination of program insight. Now for the next slide, we're going to talk about the barriers of the implementation, the possible barriers that we will face during the implementation phase. First, we will the first barrier that we thought of is the digital accessibility. If people will have no devices to use the app, there will be a 16 smartphone that will be purchased and available for the use of people who are not able to afford a device to use the app, for the mothers, and they will be trained on how to use it for sure. The second barrier is health literacy. The MatNet app was developed in a simplified way, which is suitable for all population and for educated mothers and uneducated mothers to use it. As for the security and privacy concerns, robust data encryption and security measures were built into the app in the app development phase. Another barrier is the user engagement. It is a challenge on how we can maintain the interest and engagement of users in the app. This barrier, we can approach it by having interactive strategies built on reward systems, for example, so we can sustain their engagement in the app for them to use it. Okay, for the next slide. Okay. Yeah. So, who will be working on this program? We have first our program director, Dr. Queen Jacques. Her responsibilities are to oversee the strategic planning, implementation, and coordination of the program, of the maternity program. She will also lead the collaborations and manage the progress and guide the team toward the achieving of the objects. Then we will have the Director of Finances, Development and Partnership, Ms. Yasmin Jafar. She is responsible of managing financial aspects, foster partnerships, and guidance of sustainable growth. She will also be responsible on ensuring effective resources allocations and alignment with the program goals. And then I come for the rescue. I'm the Director of Clinical Research and Community Outreach. My name is Mira Krayem. My responsibility is to oversee research initiative, engage stakeholders, and ensure the program relevance and effectiveness to improve our goal, which is the maternal health outcomes, and to reduce the maternal health mortality. We are aiming to implement this project through partners, which will help us in order to reach the key stakeholders, to plan and to recruit, and to implement, especially in the second phase. We thought of the local health department, which are interested in the maternal health. The community organizations and NGOs, especially in Arkansas, since it is our area of implementation, and the faith-based organizations, such as the Catholic Health Association of the United States. Okay, we have used the logic model to organize our work. We went through from the inputs to the activities we're targeting and the outputs. Here we're going to focus on the outcomes, especially what are we aiming to see after we finish the implementation phase, and especially in the phase in the progress phase. So as for the short-term outcomes, we hope to see we are aiming to see an improved awareness of maternal health challenges, increased engagement with app features and resources, enhanced knowledge among participants regarding pregnancy health, higher rates of telehealth consultations utilization, improved monitoring of maternal health indicators, and timely intervention in case of potential complications. As for our intermediate outcomes, we aim to see a decreased incidence of maternal complications and mortality rates, and enhanced self-efficacy and empowerment among the participants and the stakeholders we're targeting. A strengthened collaboration between participants and healthcare providers such as doctors and mental health professionals, and positive feedbacks from the community, partners, and stakeholders who were involved in this program. As for our long-term outcomes and sustainability, we aim to see substantial reduction of maternal mortality rates, improved maternal health outcomes across racial and ethnic groups, strengthened maternal health support, infrastructure in Philippines country Arkansas, a replicable model for addressing maternal health disparities in other regions. Okay, and now how we are planning to evaluate this program and the stages of the program that we talked about. We are going to do this in four levels. First, okay, I will go quickly. We're gonna monitor the app features using by tracking the symptoms, the user input, by tracking the telehealth consultants, the frequency of the calls, the duration, and how satisfied the user are from this. We're gonna track the vital signs data and have the app metrics, downloads, error rates, and user engagement, and the feedbacks on the app. The second one, which is, can you, yeah. Okay, so the second one, which is the surveys and qualitative data. As I said, as Vincent and Yasmin said before, we're gonna have surveys gathered from the workshops before the app, before the implementation of the app. There will be surveys for stakeholders and survey for partners and the cooperatives. These surveys will be short and yes or no answers. The third one is the functionality, evaluation of the functionality and user assessments. We will have this evaluation through monthly report and statistical analysis of the inputs of the users through the app. For the fourth one, we will have the evaluation of impact, which we will build up on our whole program efficiency. We will compare the mortality rates before the app implementation and after the app implementation, and we will do the post surveys to check whether the stakeholders and partners have changed, what behaviors have changed through the app after that. As for the dissemination, we will outreach our partners and stakeholders by direct engagements with partners and policymakers, such as phone calls and meetings and workshops. We will also have partner outreach and awareness. We will have a trial phase for users, maybe 1 month the trial, so they can use the app and check it, and that we will collect their feedback from it and build on it and change the stuff within the app through their feedback. For other disseminations aspects, the social media and online presence, we will be present on all social media platforms such as Facebook, LinkedIn, and we will have regular daily posts, and we will be engaged with influencers who maybe we will have live events with them so they can talk about the app and raise awareness about the matter. We will also have local outreach and media utilization requirement. Here we will use brochures and flyers that raise awareness with a barcode of the app. So each one will see it, will be able to use it and download the app. We will also have an advertisement after the news, maybe in some channels, so we can spread the word on the matter and on the app. We will also build a research and research papers and academical outputs from the inputs we gather from the app, and we will be publishing it for more benefits, for future benefits and future changing in the app. Now I guess we reached our budget. As you can see, we divided our budget as following: some 87,500 for personnel, for the equipment and tools, $13,000, and for the supplies $500, for the workshops 3,000, and we have 1,200 for the entire cost. The grant is a total of $120,000. We have reached our conclusion. All in all, this maternal nets program addresses the critical issue of maternal mortality, aligning seamlessly with the focus of Grand Challenges Canada request for proposal in maternal and newborn health. It employs a comprehensive that combines cutting-edge digital health technology and user-friendly platform for expecting mothers to manage their health. Of course, raise their awareness. We will be partnering with local community organization, health provider, and faith-based institution. We will ensure that our initiative resonates with the diverse needs of expecting mother. It will be designed in 3 phases: the development and testing, pilot implementation, and evaluation report. We are seeking a $120,000 grant from the Grand Challenging in order to contribute to sustain the developing of this project. The following are our references that we based our project into. And thank you. We welcome all of your questions, and it was a pleasure to talk to you today.
Amazing. Thank you so much, Group 1. I think we learned a lot. However, I must point that the presentation was really too long. We could have done really shorter amount of time so that we can have time for others. But that's the feedback from a professor. You know, I will always give feedback. I learned a lot. I learned about the burden of maternal mortality. I didn't know about Arkansas. So we're going to have the second group present. But before that, join me and let us give Group 1 a virtual hands of applause. And you can do your doing this, and I'm doing that. Really, 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 really incredible. Very solid presentation. Really solid presentation. Okay, so we're going to keep questions. I saw a couple of questions. We're going to keep questions and take Group 2. Then after Group 2, we are going to take all the questions together. Sounds good?
Yes.
All right, Akila, the virtual floor is yours. And I'm going to give you, when you get to the point, I'm going to give you 5 minutes to the end of the time so that you can wrap up.
Okay. Can you see my screen?
Coming
Not
up.
yet.
There's
Coming up.
On share and point to the right screen. Maybe you have 2 screens.
It says the share screen is loading.
Oh, it's loading.
Yes,
Yeah, so
there you go.
Okay, you can see, okay. Yes. So our project is Thrive Together, Elevating Nigerian Youth Mental Well-Being. I'll start with Cambry. You can start introducing yourself, Cambry.
Okay, perfect. I'm Cambry Rhodes. I graduated from Eastern Connecticut State University. I got a bachelor's of science in health science, concentrating in public health. My interest in public health stems from more of a community outreach point of view. I really enjoy bringing a community together, whether it's a rural community or an urban community. So yeah, we can move on to the presentation outline.
I'm sorry about that.
It's okay. So for the presentation outline, we have summary. What is mental health? Factors that contribute to mental health disorders. Nigerian youth and mental health literacy. Nigerians' awareness and perception of mental health. State of mental health care in Nigeria. Mental health disorder prevalence among Nigerian youth. Pathology, staffing, budget, program evaluation, and questions. So this is our summary slide. As of 2020, the Nigerian population is 206 million individuals, which is the largest population within Africa. The age group 15 to 64 accounts for about 54% of the total population. So for Nigerian youth, they experience suicidal ideation and behavior 3 times more, which is 12.4%, than any sub-Saharan African desert. Tanzania is 4.6%, Ethiopia is 1.2%, and Ghana is 4.0%, for examples. Can you move the slide up?
Yes, I'm sorry, there is some technical difficulties. I'm not sure. 1 second.
Did you time the slides? If you timed it, then it will be moving automatically.
No, I didn't. I'm not sure what happened.
Is this the same slide that you shared with me? I can share from my own.
Yeah, yes.
Okay, 1 second. Let me pull that out. All right. Could you stop sharing?
Okay.
Cambria, I will be sharing for you, and you just let me know by saying next, okay?
Okay.
I will be your Uber driver today. Here at your service. Go ahead. Can you guys see my slides?
Yes, thank you.
Okay, so we go. Yep.
I'm on the next one.
Yeah.
Okay. Between the years 2016 to 2019, 30.1% of Nigerian youths 18 to 29 years old completed suicide. The World Health Organization reported in 2019
17.3 per 100,000 deaths were due to the completion of suicide in Nigeria. Next. In Nigeria, 3.6% of youth 18 and under in the workforce was eliminated due to suicide in 2015 through 2019. 21.6 billion naira, which is $166.2 million US, spent on societal level indirect healthcare for mental illness in 2012. Only 10% of Nigerians with mental health disorders have access to treatment. Next. So our program goals is to provide education and awareness of the prevalence of mental health disorders in Nigerian youth. We are creating a platform for youth to take anonymous stress and depression assessments, which is to provide access to mental health therapists through a mobile software application. Next. Thrive Together will do this by introducing a mobile phone application called Mindful Connect. The youth who download this application will be able to access wellness resources, access stress management information, take self-assessments on the key risk factors. Based on a score, youth will anonymously connect with a mental health professional. So our program objective, Thrive Together, seeks to increase awareness of the risk factors for mental health among youths and reduce the prevalence of mental health disorders in Ibenin, Southwest Nigeria. Over to you, Akila.
Yes, hello everyone. So my name is Akila Robinson. I'm currently a doctor of public health candidate at Capella University. I currently reside in Brooklyn, New York. I hold a master's in microbiology from Long Island University in New York City. And one brief thing that drew me to public health is my passion for improving the disparities in literacy of public health. I will be continuing the discussion of mental health issue in Nigeria, focusing on the prevalence data and factors that contribute to the prevalence. Next slide, please. So what is mental health? The CDC states that mental health encompasses emotional, psychological, and social well-being. Mental health plays a role in how people think, feel, and act. And mental health helps in the determination of how a person can handle stress, how a person connects with others, and a person making healthy choices. Maintaining a good mental health status is important throughout all the milestone development stages in life. Next, please. Some of the factors that contribute to mental health disorder prevalence in Nigeria is the socioeconomic inequality, poverty, unemployment, political instability, domestic violence, lack of awareness and education, substance abuse, inadequate healthcare infrastructure, domestic violence, genetic and biological factors. Next slide, please. And Nigerian youth and mental health literacy, a 2018 study shows that the mental health literacy is low among Nigerian youth in grades 10 through 12. Next slide. A polling survey conducted by the African Polling Institute in 2019 states that mental health awareness is low in Nigeria, and the survey respondents acknowledge that they do have a mental health disorder, but their perception of their mental health illness is due to drug abuse, sickness of the brain, or possession by evil spirits. The respondents think that a spiritual intervention is the best effective treatment. Next slide. The mental health care in Nigeria is faced with 6 challenges, and these are traditional and religious beliefs, stigma, resource allocation, infrastructure, non-governmental organizations, and psychiatrists. So I will dig a little deeper into these few issues. So the stigma, mental health issues are often stigmatized in Nigeria, leading to underreporting and a reluctance to seek help. This stigma poses a significant barrier to access of mental health care. In resource allocation, Nigeria faced a shortage of mental health professionals, including psychiatrists, psychologists, and social workers. The shortage limited the availability of mental health services, especially in rural areas. For infrastructure, the mental health facilities and infrastructure were often inadequate and in need of significant improvement. Many mental health hospitals and clinics lack essential resources and funding. And some data that I have found also is that only 3.3 to 4% of Nigeria's central government health budget is allocated to mental health care, and that Nigeria has a 1 in 700,000 population ratio relation to psychiatric care. In regards to traditional and religious beliefs influence how mental health issues are perceived and managed. In some cases, the individuals with mental health problems were subjected to harmful traditional practices. Yes. And the Kutcher Adolescent Depression Scale on youth age 10 to 12 from 6 sub-Saharan African countries found that 27.2% of youth ages 10 through 15 from Ibadan, Nigeria, have symptoms of depression. And a child depression inventory conducted on youth ages 10 through 15 from Ibadan, Nigeria, found that 23.8% have mild symptoms and have 5.7% have severe depression. And this is due to low levels of physical activity, more prevalent among females and older adolescents. Next slide, please. And from a patient health questionnaire in 2014 on adolescents aged 10 to 15 from Southwest Nigeria, it found that 21.2% had symptoms of depression, 16% of adolescents had moderate depression, and 4.6% have moderately severe depression, and 0.5% have severe depression. Next slide, please. And the severe depression was due to not living with their parents, recent change in the living environment, having a large amount of siblings, and also a low level of physical activity. Next slide, please. A 2019 study showed that Nigeria has the highest prevalence for suicidality, which is ideation, plans, and attempts among youths ages 10 through 19 years of age. Next slide, please. And females had more reports of suicidal ideation, behavior, and plans. And these feelings were due to gender, older age, feeling lonely, food insecurity, poor access to health, and worries that lead to sleeplessness. Next slide, please. The Health Believe model constructs of perceived susceptibility and perceived severity are the focuses within the program. So educating the Nigerian youth on the risk of mental health disorder allows the youth to take action and to avoid any negative behaviors. Next slide, please. So I will pass on the mic to Kwame, and he will go into our social media intervention to address the mental health issues in Nigeria. Thank you.
Hello, everyone. My name is Kwame Manu. I hold a Master of Public Health with a concentration in nutrition from Liberty University. Currently, I am a Public Health Fellow at Global Health and Education Projects. So Global Health and Education Projects is a nonprofit organization dedicated to eliminating health disparities by addressing the non-medical factors that influence health outcomes. And also, I'd like to say what drew me to public health is my passion to improve the quality of lives of people through preventive medicine. Next slide, please. So, social media intervention. This program will utilize a customized software application available on both Apple iOS and Android mobile devices called Mindful Connect. Mindful Connect will enable the youth to have access to anonymous self-assessments for stress, depression, and other mental disorders. So this application provides wellness videos on work-life balance, information on navigating trauma, information on navigating substance abuse, suicide prevention, post-traumatic stress. Next slide, please. So Mindful Connect has several features. The most notable of this feature is the ability of the application to link mental health therapists to users who based on the self-assessment scores. And this is done in a confidential manner that provides the privacy of the patient. Next slide, please. So staffing and personnel. The project director is Akila Robinson. Some of her duties will include overseeing the coordination of personnel and resources required to successfully complete the project. The clinical director is myself, Kwame Manu. I will assist with the assessment of clients and develop treatment goals using client input, strengths, abilities, needs, and preferences. The data manager will be a consultant. Some of their duties will include organizing, storing, and maintaining the collected data. The outreach coordinator will be Cambry Rhodes. Some of her duties will include planning, directing, and coordinating activities designed to raise awareness of mental health issues affecting the youth. The digital creator will be a consultant that we will hire through a grant from NIH. Next slide, please. Methodology. So this program will recruit 500 youths aged between 13 and 22. So some of the channels of our outreach will include online outreach through a dedicated website and social media presence. We will also recruit through local events, fairs, community meetings to raise awareness about the program. We will also distribute flyers and posters at schools, churches, and community centers. Next slide, please. So the program will collaborate with local media outlets to feature stories and interviews about the program. The program will last for a period of 90 days. All participants will require written consent of a parent or guardian to participate in the program. All participants will unanimously take a survey that will highlight a mental health disorder from economic hardship, food insecurity, unsafe neighborhood, multiple adverse childhood experiences like substance abuse, domestic violence, severe emotional, physical, or sexual abuse. Participants who fall into this category will be provided mobile phones with the Mindful Connect application, which provides the resources we earlier stated. Next slide, please. Budget. So our budget for the Thrive Together program is as follows. Program director, we have budgeted $25,000 for the program director, $23,500 for the clinical director, $23,500 for the data manager, and $17,422 for outreach coordinator, $30,578 for a digital creator, and which brings the grand total cost to $120,000. Also, we will be using some grants from NIH, which is the National Institute of Health, to develop our mobile application. That brings us to about $13,000. The cost for advertising is going to be $5,000. The cost for mobile phones that we will be using this program is about $8,000. Indirect costs for transportation and other miscellaneous costs will come up to $12,000, bringing the whole grant to a grand total of $38,000. Next slide, please. Program evaluation to measure the success. So the evaluation of the program will occur at the beginning, in the middle of the program, and at the end of the program. As I earlier stated, the program will last for 90 days. Bi-weekly meetings will be held with the program team and stakeholders to review evaluation data to ensure targets are met. Next slide, please. So program evaluation to measure success. What will be evaluated? Process outcomes. So we will be looking at the application downloads of Mindful Connect, where we will be looking at about 200 downloads within 30 days, 400 downloads of the application within 60 days, and 600 downloads within 90 days. Response rate, we will be looking to gather data on how many persons open the resources in the apps. And we will gather data from the app survey from participants about clarity of the information shared, the helpfulness of the information to improve their mental health disorders. For participation and retention in the program, you will have an incentive of a $25 USD Apple, iTunes, or Google Play gift card, which will be given to participants. Next slide, please. And this brings us to the end of our project. We will take any questions you may have at this point.
Very good. Let's give group 2 a round of applause. You can unmute. Wow. This is really, really nice. Really, really nice. Very good. Okay. The questions are pouring in. I have like 5 questions already. Oh, okay. I didn't know we are going to have a lot of questions. For group 1, how did you decide where to implement your program? I think the person is saying you will be implementing this program in the entire United States. You have selected Arkansas, which is one of the 51 states and the district. Why did you decide, how did you select Arkansas as the place to implement your program? Group 1, who wants to take that?
I can speak to that, and then if any my team members want to add to that, they're welcome. I think we talked about our program being very data-driven and evidence-based. We looked at the data collected by the CDC between the years 2018 to 2021, and the data show that the southern region of the United States, which includes Arkansas as a state, was having the most problems with maternal mortality. Now, the average for the whole country was 32.9 deaths per 100,000 live births between these 3 years. However, in Arkansas, that figure was 43. So you see that there was a huge difference, and that's why we chose to target Arkansas, because it's the region with the highest maternal mortality rates.
Excellent. That makes sense. Then I have a similar question for group 2. Wait, the question says, I am curious how group 2 decided to work in Ibadan, Nigeria, but is in the southwest of Nigeria. So I think that's the same question. Why did you select Ibadan out of the entire Nigeria that has 31 states, right? And the federal capital? Why Ibadan, which is in southwest Nigeria?
Yes. Majority of the data that I was finding in regards to mental health was in that section of Nigeria. So I thought that it was best to work with that area.
So the determination of the target area was based on availability of data?
Yeah, and also
Can I chip in?
yes, you could chip in for me. I'm sorry.
Okay, so we decided on Ibadan, Nigeria, because that was the data that was available in Nigeria. So looking at a lot of African countries, finding data about mental health is it's not the easiest. Their data is not published, it's not readily available. So we were fortunate, Ibadan is the data that we came across and found it very interesting to use. That's why.
Very good. I had another question so first of all, a comment. Member of the audience said, for group 2, I really like the way you talked about your anticipated downloads from the mobile application. How would you these are youths who may not have money. How would you ensure that they can really afford phones as well as the applications to participate in this program?
I will take that question. So we have already, through the program, we have already made funds available for mobile phones that already have the Mindful Connect application installed. So they are readily available for the youths that qualify to be in our program, and they won't have to purchase it out of their pocket. It will be provided to them.
Okay, yeah. And then another question for group 2 again is the question said, this person asked, one second, let me. Okay, the person said that you said that you are going to connect. I like the idea of connecting the youths with therapists. So are these therapists going to be based in Nigeria, or are they going to be based outside of Nigeria? And who will they be? Are they going to be psychiatrists, psychologists? What are these therapists? Who are they going to be?
That's a very good question. So through the application, we will enroll medical health professionals, psychologists, psychiatrists, and other mental health providers in the application. So users will be linked based on their scores of the self-assessments. And we are going to make sure that these are licensed professionals, and they will be able to provide every need that these users would require to help them live successful lives in their communities. So, and what was the other question, Dr. Rahman?
I think you answered it. I think the concern here is determining whether the services, or those who are going to provide the services, ensuring that they have the required licensing in order to deliver care, right? If they're going to deliver care in Nigeria, you need to make sure that if they are not in Nigeria, that there is an approval process. Or you can say, once they have a license wherever they are located, right, that you can verify, then they can deliver the care, through telehealth. I think that's what they were saying. And then how you are going to enroll them, are you going to work with medical associations, with psychology associations, with counseling associations, just to make sure that you are enrolling individuals that do really have that particular work? Then for the maternal mortality group, I think one question came on there saying, I am surprised that this intervention is not focusing on Black women. Really, so because I think everybody knows that Black women and even your data demonstrated that more than any other group are more impacted by maternal mortality in the United States. So the person is saying, can you tell me why you are not focusing exclusively on Black women? Group 1.
Yeah, so I can answer that. First, let me just say that's a very good question. Within our whole presentation, I know it was a lot, but we actually didn't get to speak to it. But so within our inclusion criteria, we also have that we will actually recruit the three big races. So the white, Hispanic, and Black. So non-Hispanic Black, and non-Hispanic white, and then Hispanic. So our target is to at least get a minimum of 2 people for each of those 3 groups, and that's so that we can evaluate the diverse needs of each group. Now, we did say we would recruit at least 16 people, so the rest of that will be more focused towards targeting Black women, because that is what we want to target and recruit and look at. But in order to ensure that we are kind of looking at that diversity and to actually make a case for how much it affects Black women as well, even though the case is there, we do plan to actively recruit Black women mostly in our recruitment strategy.
Okay. Then I had another question. These are really interesting questions. These other questions said, I know that your program is targeted towards the United States. Can this maternal mortality program also be presented in Africa?
So part of our, so I should mention that this program is a pilot study. So meaning that we're just testing the waters to start. And as Yasmin described, we're testing it first in Arkansas, specifically Phillips County. But one of our long-term outcomes and goals that we would like is to have like everything that we got from this program and all the feedback, and to be able to say, okay, we can improve this by this, and then be able to implement this program in other places. So other places in the United States or other places in the world. So in the immediate vicinity, it's not something that can be applied at the moment because we want to ensure it actually works. But in the long term, we would love to implement this program worldwide.
Great. While I am reviewing other questions, please, if you would like to ask your questions or commend the groups for their presentation, please feel free to unmute yourself and speak, or you can raise your hand and then we will unmute you so that you can ask your questions. I know that only some people have chatted in their questions, via text. So if you want to ask any question or comment the group, please unmute yourself and go ahead. Any questions, any comments, any feedback?
Yeah. Thank you, Dr. Remy. I want to thank the members of groups 1 and 2 for their tremendous work. I know they put in a lot of time and a lot of work to produce this good work. The taste of the soup is in the pudding. And I think I have to say kudos to them. And I'm looking forward to these programs, both for the maternal health and mental health in Nigeria, to be upscaled to anywhere and be applied anywhere else. Since these are your pilots, I'm thinking that your lessons learned will help improve the program, so you'll be able to upscale it and take it to anywhere else in the world. But I just want to say kudos for a job well done for the two groups.
Thank you so much, Dr. Susan. That's very, very helpful. I have one question. I think this is for both groups, so we can start with group 1 and then group 2. He said, I did not see much about where the group said whether the programs will work or not. What if the programs do not work? What would you do? So group 1, that's really, I like that. That's really like a question that I will ask. That's me. I didn't, everything seemed to be, we're going to do this, and assumes that everything is going to work like that. So what will you do if this program does not work? And how are you going to, pick yourselves up from the ground, if you just find out that this your program did, that you've just spent all your time and all your resources in a program that did not work? Who is brave enough to start? Group 1, you go.
I can.
Go ahead, Mira. Yes.
Yeah. Okay. So our evaluation approach is built on the fact that we are going to have the evaluation month by month, because it's an app. Maybe we will have a problem or a limitation of an outreach. Maybe we have a limitation in the engagement of the users and stakeholders, or the outreach of the partners, the engagement of the partners, and maybe we will have a limitation within the app and within the app features. That's why we said that we're gonna have a monthly progress report on technical issues on the survey day-by-day surveys within the app, within the that the stockholders can fill, and then we can have the plan B and C according to the result we're having within the pilot period. And if the evaluation approach was not successful, then we will build on the data that we collected at the end, at the phase 3, and make case studies from samples of the stockholders to develop a more mature app from our experience on the pilots.
I think, Mira, you taught all of us something, and that is the humility to accept that a program has not worked. We will do our best to learn, and if after all our learning as data-driven people, we see that that program is not working, we scrap it. We should be brave enough, to tell our stakeholders, we thought this was going to work, this has not worked, and we scrap it and we start all over again. You remember, each of you in the program commit to a set of core values, and one of them is honesty. You have to be honest to the stakeholders, you have to be honest to your team, you have to be honest to the community to tell them that we thought this was going to work, this hasn't worked, we have evaluated it, and we are convinced that this is not a program that is worth scaling up. So I do really appreciate that. So for group 2, what are you going to do? You are all assuming that this program was going to work in Ibadan. You go to Ibadan. They tell you, we don't want you talking to our youths about mental health. Or you set up the program, nobody signs up. What are you going to do?
So we would do more research for more areas to see how they would be receptive to mental health and learning about mental health and trying to implement it elsewhere, so that if you go use someone else as an example, maybe another person will say, hey, they tried it, they said they like it, let's see. So something like that.
What if you try all that and it's still, let's take recruitment challenges, for example. You have all your funding, all of you have implemented, you've done all the research, you go live for Thrive program. 1 week, 2 weeks, 3 weeks, nobody's enrolling. You don't get anybody enrolling. Maybe you have healthcare professionals all enroll because they want to help, but you get really no youth. Nobody is enrolling because, there is a lot of stigma around mental health issues, not only in developing countries, even here in the United States, there is a lot of stigma around mental health seeking behaviors. So you've done it 1 month, 2 months, 3 months, nobody's enrolling. What are you going to do?
Yes, I would. We'd have to.
This is not for you alone. You have other group members. They should weigh in as well.
Okay. So I think if we're having a hard time getting participants after 3 months, and we need to, there must be a miscommunication or a disconnect somewhere. Maybe people are not understanding us, so we would have to provide more education, because once people understand, they're more likely to take action. So maybe the information we're putting out is not good enough or something. So we would have to provide a better education, and also has to be culturally sensitive, because Nigeria is a different part of the world, and we'll have to appease to what they understand and make it easier for them to consume the information we're giving them. I think when that happens, they'll be more likely to participate, especially when they know the benefits of the program. Yeah.
Okay. So for both groups, when you are new in a culture or in a location and you're a public health practitioner, you want to implement program, can you articulate what your strategy for engaging that community could be, right? You remember, you have been in Public Health 360 as hands-on frontline workers. You are not theory. Theory in school, they tell you that everything is going to work as planned. What are some of the strategies you are going to use for a new environment you have come to? You want to implement a new program in a new county, in a new state, in a new local government area, or in a new district. Can you walk us through some strategies that you are going to use to introduce a new program? And we can start from group 2 and now go to group 1.
Am I talking? Somebody wants to go?
Maybe, yeah, let me chime in and maybe clarify what Dr. Rumi is saying. I think you have to go by identifying a protagonist. You must have to find someone. That will be your first thing. Find someone who's going to lead you culturally and otherwise to the people that you need. So I hope that you've understood what Rumi is trying to say.
Yeah, so I think a good start would be like going to like the local health departments, like talking with them and getting more information about the culture of the people, to work with cultural representatives and kind of work with the public health professional and like the cultural person kind of hand in hand, so it can be work with persons a little bit easier.
What else?
I think that if we're working with kids, that we should go to the source, so we should see how they interact, what they like, to help better market our app. But not only that, we're creating a rapport with the kids, so they would trust us more.
What else?
Okay, so I think especially for our program, the age range for participants is 13 to 22. So we're looking at kids, people who won't be able to make decisions on their own. So we have to talk to the parents, get parents to understand what it is the program is about. So once parents understand, most kids will listen to their parents. So once the parents understand, they can better talk to their kids to educate them and let them know what this is, and the kids will be more interested.
What else? Okay, so Dr. Susan actually was leading you guys in the right direction, but you are still hung up in the theory.
Hi.
Yes, go ahead, Sam. Hello? Okay, sorry. So she was leading you in the right direction. So this is practical hands-on. You have received funding from the grant challenges to implement a program in Arkansas. You are now working in Arkansas. You have this program now to implement. You have received funding to implement this program in Nigeria. You have selected Ibadan. You've not been to Ibadan. So a few things you can do is they're always going to begin from you as a public health practitioner. You are going to begin to ask yourself, what do you really know about this area? Right? You need to make sure that you are educated. How many times have you seen people who ask you, you are from New York, they see you live in the Bronx, and they ask you, oh, I have my friend who lives in Albany. Do you know him or do you know her? And this is like ways, or for those of us who are international, you live in Maryland and somebody tells you, oh, I have a friend who lives in Maine. Do you know him? Or somebody tell you, oh, you're from Africa. Oh, yeah, I know this person from Uganda. Do you know her? So you don't want to be a public health practitioner who is really off base. You need to educate yourself about the place that you're going to. You need to understand the culture. You need to understand the language. You need to understand the people. And then you tap in on your professional network on LinkedIn, who are the people who are working in this area? Who are the leading people who are working in this area? You can do informational interviews with them just to find out from them what is their experience working in those areas. Then you move on to key opinion leaders. You are asking yourself, who among this community, in the mosque, in the churches, in the community-based organizations, student associations, which organizations are very active? And social media has made it really, really so easy these days that you can actually know based on your research. So you begin to reach out to them, introduce yourself, say, this is who you are, and you are looking to, introduce this program. Can they make time to talk to you about the area? So you begin to know that. And then the next thing you do is you actually get to look at what is feasible. And from these informational interviews, you begin to tweak your program. If you had wanted an aggressive program to recruit 20 people at the beginning, you know that that is not going to be possible. If you are talking about an area that there is a lot of stigma, talking to parents could be very, very difficult. You could actually imperil the program by talking to parents. So you need to begin with yourself. We're always quick at pointing out what we're going to do externally. You need to educate yourself personally to begin to know specifically the areas, the organizations working in the areas, and then leverage those organizations in order to have an inroad. Remember, the community does not know you. They need a trusting individual that they are going to trust, that they are going to believe that the person will not be a helicopter researcher who will just jump in and jump out, who doesn't care about the area. So you need to have your local champions, your protagonists. You're going to have really, really individuals. Yeah, Queen, I know you raised your hand.
Yeah, I just wanted to add as well that on that same note of local champions and collaborating with organizations, that it's also important to have a knowledge user. So somebody who has the lived experience that we can add on to both of our projects. So having someone from the beginning of the creation of the project to the end. So for both groups, so for Maternal Net, we would have a representative who has gone through pregnancy or who is currently pregnant, who would be on the team as well. And then for the second group, they would have a youth person, representative, who can advocate for youth mental health in Nigeria as well. I think that will add to building trust and champion partnerships.
Very good. Any other thoughts, suggestions?
Dr. Emmons and Group 1 and Group 2, thank you so much. I actually learned a lot, from Group 1 and Group 2, especially about different things that could, lead to this maternal mortalities. Thinking it was just strictly baby and mother related, but there are some other environmental factors and some other underlying health factors that you guys were able to outline. Thank you so much. And also Group 2, I also learned some of the things that do really lead to this mental health and some of the ways we could alleviate it, through this outreach and, informing and, creating awareness in the community. Thank you so much.
I thought it was very interesting that both groups independently arrived at using mobile application as a solution. So what is that telling us? That is telling us that this century is the century of technology, and individuals who do not understand technology may be left behind. However, it is also important for us to consider what we call the digital divide. So I know there is a lot of excitement about using technology to implement programs. Please always remember that there is still a lot of inequities in access to mobile technology. Here in the US, there are many places that do not really have broadband internet. There are many places where individuals cannot really afford smartphones or smart devices. So when you are, driving programs in this area, always remember, those individuals, so that we do not inadvertently begin to perpetuate these disparities that are already there. So, but it's interesting. Technology is the future. Especially in developing countries, you can actually be anywhere and implement programs anywhere you are. But always remember the culture, remember the people, and remember the incentives. Remember the inequality picture that I showed you during the program. It is not about that everybody can get it. It is about who are we providing more support so that everybody will have equal access. I have learned a lot, and I'm surprised that you guys survived 3 months of grueling with me. I'm not really nice usually. I'm not really nice, but today you have demonstrated and made all of us really proud. I'm really very proud of this cohort. The message remains the same. You are always part of GHEP. You are always welcome here. We're going to be calling upon you to become experts for us. Today, I have seen your expertise in Nigeria, your expertise in the United States, even though you do not live in Nigeria, even though you do not live in the United States. That's the beauty of this program, is that we get to meet individuals. You will remain your colleagues, your network. Use LinkedIn, leverage networking. And we have always been planning about this international conference where we bring all the years of the cohort of PA 360 together. We're still deciding whether that is going to hold in Canada, in United States, or whether it's going to hold somewhere in Nigeria, maybe Ghana. We haven't finalized. So when we reach out to you and invite you to serve on the committee, on the steering committee, please, do not be a stranger. If there are any links, any opportunities, any contacts you want to make, please reach out to any of us. We will always be pleased to write those recommendations, to make all those phone calls. So on that note, I want to, on behalf of our faculty, on behalf of GHEP, congratulate you on your graduation, congratulate you on this important milestone in your career. Having this knowledge is not enough, but what you do with this knowledge is the most important thing. I know that 2 of you at least are in grad school right now. Cambry, we are looking forward to you making your final decision, whether it's public health that you're going to go to. And then Mira, we are looking forward to the opportunity to supporting you and your education. Queen, you're going to invite us when you graduate. The same thing for Yasmin. And Kwame, when you make this connection between cybersecurity and public health, please call us, call upon us so that we can support if you are looking for grants. Akila, we are looking forward to you becoming that doctor of public health and transforming the world. So please, if you are in the DC area at any point, please let us know. We can organize lunch, we can organize for you to come actually and see what we're doing in the community. So once again, I couldn't tell you how proud I am. And I know the faculty are also proud of your accomplishments. So congratulations. Looking forward to seeing you again. Be our best advocate. We have recruited 90% of our students from former fellows. If you thought that this has transformed your life, please introduce family and friends. Let them join us and then benefit from what you have benefited from. So please, I'm going to give opportunity for us to do the last confetti, the last congratulations, the last love, that we want to give to you, just to thank you so much and wish you a wonderful career ahead of you.
Congratulations to everyone. And thank you so much. And keep going and go ahead and do great things. So ending the meeting here. See you all.